but I figured we'd get started so we have time for questions at the end and nice discussion at the end. First off, just like to introduce myself. I'm Norman Orabi. I'm a first-year medical student. MSMD, Middle East medical students of Middle Eastern descent, along with OHE, set this event up. I have to give OHE most of the credit because they did most of the work. So without further ado, let me introduce Dr. A.Padela. Dr. A.Padela is the director. Dr. A.Padela is the director of the Initiative on Islam in Medicine, assistant professor of medicine in the section of emergency medicine, and a faculty member at the McLean Center for Clinical Medical Ethics. He holds an MD from Weill Cornell College, completed residency in emergency medicine at the University of Rochester, and received a master's in healthcare research from the University of Michigan. His Islamic studies expertise comes via a bachelor's of science in classical Arabic from the University of Rochester, seminary studies during his formative years, and continued tutorials with Islamic authorities throughout his career. Dr. A.Padela is a clinician researcher and bioethicist whose scholarship lies at the intersection of community health and religion. He utilizes diverse methodologies from health services research, religious studies, and comparative ethics to examine the encounter of Islam with the contemporary biomedicine through the lives of Muslim patients and clinicians, and in the scholarly writings of Islamic authorities. Throughout systematic research and strategic intervention, he hopes to improve American Muslim health outcomes and healthcare experiences, and also to construct a multidisciplinary field of Islamic bioethics. Also, as a Robert Woods Johnson Foundation clinical scholar from 2008 to 2011, he developed a community-based research methodology to study and intervene upon American Muslim health disparities. In 2010, as a visiting fellow at the Oxford Center of Islamic Studies, he studied Islamic moral and theological frameworks, and from 2013 to 2015, as a Templeton Foundation scholar, he led a national survey of Muslim physicians' bioethical attitudes and professional experiences. His current areas of research in cancer screening, end-of-life care, neuroscience, and theology are all funded by the Templeton Foundation and the American Cancer Center. Please welcome Dr. A.Padela. Thank you.
Thank you for that introduction, Norman, and thank you to the I guess it's called OHE, but the office and the Medical Student Associations for bringing me here. This evening, I'm going to speak part two of what I spoke about this earlier today. And earlier today, I presented a lot about cultural accommodations and healthcare accommodations for Muslim patients. And this evening, I want to challenge you to think about what that looks like in the healthcare workforce for Muslim and other sort of physicians of religious identities. So with that said, my talk today is going to talk about workforce diversity in healthcare, both the ethical and practical motivations of that notion. I want to present some data on discrimination in the physician workforce, then move to talking about the population I'm most familiar with, American Muslim physician population, who they are, as well as data from this national survey of their experiences that Norman just mentioned. And at the end, I want to challenge you through some reflections regarding the accommodating religious identity of the healthcare workforce. I think that is part of the mission of OHE, which brought me here, so I want us to think about that in a deeper fashion. So starting with talking about healthcare workforce diversity, there are many different ways that one can think about why this is a mandate and an ethos for us today. But at one level from the society, you can think about this, that the roots are, the underpinnings of this notion of healthcare workforce diversity are rooted in social justice. And that it aims to address historical and in some cases still present marginalization of minorities by providing them equitable opportunities for upward mobility. Right, so we're trying to right the wrongs of people before us or even of wrongs of people outside this room. So this social justice mandate underpins some of the work. On another level, you can think about this as emerging from human rights, right? So if we adopt this notion of universal human rights, that maybe there's a right of the human upon another human, that we promote the access to the pursuit of their happiness or flourishing in equitable ways. At the patient level, we have a lot of research actually discussing what this means. And so one of the models that I like is from the Sullivan Commission that talks about what arises from increased diversity in healthcare professions. So one of the things that arise is that you have greater service in underserved communities. We know that people from minority backgrounds in the health professions, they disproportionately service underserved communities. That can lead to, or does lead to, improved access to care for people in these underserved communities. That engenders improved quality of care, and the health outcomes are improved for that underserved community. At another level, you can think about the fact that increased diversity leads to a greater concordance, ethnically, racially, linguistically, and that leads to greater, more effective patient-provider communication and trust, which then impacts quality of care, higher quality of care, and then thereby improved health outcomes. Another way that increased diversity helps, has positive outcomes is through greater trust in the healthcare system, again by disadvantaged groups, right? So you have people who come from your backgrounds, that engenders greater trust, that improves access and use of health services. So if they were perceived barriers related to trust, then you would have less of those barriers. That improves quality of care and then improves health outcomes. Lastly, this idea that those, and we have data behind this as well, that individuals from minority backgrounds, they often play greater advocacy roles for people from their backgrounds, like sort of what I'm doing today. And that can hopefully lead to improved use of services, improved quality, improved health outcomes. So we know this from a patient level. So societally, we have these social mandates. Then from a patient level, we posit, and there's a large body of literature that shows that we do improve health outcomes. The question, if you pose that question at the staff level, what do we know? Well, we know that when there's greater diversity, we can promote a more tolerant, hopefully a welcoming, but at least a tolerant work environment. And individuals from minority backgrounds then have increased productivity and satisfaction with their jobs. That leads to decreased recidivism and job turnover. Okay? Then lastly, it cycles back to increased knowledge about the other. So when you're working next to someone from a group that you've never interacted with, you get to know about them. And that can lead to you better serving patients from that population, because now you know about their cultural values, about the things that are important to them. So we believe this is a benefit as well. Lastly, having people of diverse backgrounds in the healthcare workforce creates a socially inhibitive environment against bias and discrimination. Right? So that is also another benefit that cycles back to every level, patient level, as well as the staff level. So it's a rosy picture. We should all be doing it. We should have a lot of diverse staff in our healthcare environment, and we should all be smiling. But the proof in the pudding is that when you have greater diversity, you can have discrimination. So these are 3 large studies done in the United States over the last 10 years that talked about discrimination in the healthcare workplace. So this was done in Massachusetts. They oversampled international medical graduates and minority physicians. They found that of this group, 63% reported discrimination at the current workplace. And those who did, what were the associations or the predictors? International graduates, racial minorities, and women. That's Massachusetts. Then if you take a national sample from the AMA master file, plus oversampling from the National Medical Society, which is largely African-American physicians there, they asked questions about discrimination over the career. You found 71% of African-Americans, 45% of Asians, and the lesser proportion of Hispanic Latinos compared to white. Okay? Currently, and this was done in, I think, 2004 or 5, currently, they face 59% of African Americans said they face discrimination, 39% of Asians, and then a quarter of Hispanic Latinos. So this is a national sample, moving from Massachusetts nationally. Then you think about, okay, of the national sample, let's look at where we think this shouldn't occur, academic centers. So yeah, when you do that sampling, they sampled, as we do most of the time in med ed or here learning health sciences, with underrepresented minorities and non-underrepresented minorities, all this lingo. But here, what you got? So 46% of underrepresented minorities, largely African-American Latinos, reported discrimination over their career. They're working as faculty at medical schools. And then 26% of underrepresented minorities. So it's not quite the gleeful, rosy picture that we have. But this is it. This is all we know nationally. No further study has been done. All right. So what do we know? Right, significant numbers of minority physicians experience discrimination based on what aspect of their identity? Their race, ethnicity, their gender, and the fact that they come from different countries. And we know this, that discrimination at workplace leads to increased job turnover and decreased satisfaction and productivity. So it's really a workforce issue, right, for these types of physicians, which means everybody is not majority, right? And that will change when we have a different majority. Okay, so what I think about discrimination in the healthcare workforce is that we often don't hear about the problem because we don't study it, right? People who are championing it don't talk about it, and the policymakers don't see it. So lack of research leads to lack of data-driven policies, which leads to a lot of myths, and then nothing happens. So my particular shtick is to look at religious identity. So there was no, I told you the last national studies, there was no examination of how religious identity relates to experiences of discrimination in the healthcare workforce. So I set out to do that with the population that I'm most familiar with, American Muslims. So before I present those data, let's talk a little bit about some myth busting, who American Muslim physicians are, and how do we know Islam impacts their practice. So this is a snapshot of American Muslim physicians, right? They comprise nearly 5% of the physician workforce, which would mean greater than 50,000 people. And the only way we get at this number, because the AMA master file does not collect religious affiliation, would be by looking at immigrant populations and saying, okay, this country is mostly Muslim, this is how much percentage of the IMG pool they contribute, therefore this is how many Muslims would get at. It ignores people like me, born here in the United States. No idea what percentage, right? So, and if you think about the fact that between 1 and 2.5% of the population of the United States is Muslim, this is a multiple fold over representation. Okay, a very, which I was told when I was interviewing for medical schools. Why do you want to be in medical school? We got a lot of you. So seriously, so right. So that's the perception. So when you think about the international medical graduates, I just want you to know that in the top 20, the number one country is India, right, which has 20% of that population is Muslim, but we don't know what percentage of the people who come here are Muslim. And these other countries are all 99%, 98% Muslim as well. Okay, so a lot of foreign medical graduates working and largely where do they end up going? They go to places where there's a lack of physicians. So what do you think their experiences would be as international medical graduates and then as Muslims in our society today? So that's the study. We have to go any further, right? You'll see the data that shows up. In terms of the American Muslim physician population, they're very active in the Muslim community and they're highly religious. I'll share some data. And we know, and this is a running joke in our culture, right? So if you're from South Asian descent, there are only 2 professions that exist, right? You have to be a doctor, you have to be a lawyer. That's it. There's nothing else. So it's very highly valued, which pushes a lot of people to become physicians. As you see, that's why there's a mismatch. So I did this study in 2006 when I was a resident, and I wanted to understand the role of Islam in immigrant Muslim physicians, how they thought about Islam informing their their professional identity. So we found that the larger portion of them talked about the idea that Islam informs their virtues in medical practice. I'm more trustworthy as a doctor. I feel I have to be trustworthy because Islam tells me to be trustworthy. These sorts of ideas, and that in terms of what Islam informed their scope of practice. So people would say that, there's this issue about gender concordance and gender relations. So as a man, I decided not to go into OBGYN because Islam, I wanted to be respecting the modesty rules in my religion, or the fact that I wouldn't do certain procedures, right? So I'm not involved with cosmetic surgery because I have questions about whether that's ethically appropriate to augment people's breasts. So I'm not going to do that. So there were this choice of specialty, and then the scope of practice within specialty at times was informed by their notion of what Islamic law and Islamic ethics tells them to do. But it also presented some challenges. So I'm going to read this quote because it illustrated what they felt the challenges were. So this was a female physician. She was, sources says, I was seeing a female patient in his 40s. As I entered through the door, he said, "How the hell did you get your education? We see day and night on TV, the ladies in Afghanistan are tortured. They don't have any rights. They can't go out. They can't do this or do that." So I said, okay, Islam doesn't teach that. I got my medical degree back home, and I couldn't really believe the way he did talk to me. So as a female physician from the Muslim population, she felt that she often had to explain how she got there, and at times people didn't believe that she actually had the training to actually do something, right? How can they teach you medicine in Afghanistan? They don't know anything. So she would be challenged like this. Another female here talked about this idea that she was interviewing, and everywhere she went, I felt guilty. I was sort of forced to shake their hand, especially if it's somebody in a position of authority like a program director. So she didn't feel comfortable shaking people's hands, a different position within Islamic law, which I think actually should be, personally, I'll just give you, I think that is a big thing for the patients and providers. But she felt that she always had to do this, and that was what she felt, that they didn't accommodate the notion that I'm just not going to shake my hand, and that somehow or other then I would be graded less or looked at worse when I'm applying for residency positions. So that's 2006. What do we know about the anti-Muslim climate today? So what happens in society does filter into the healthcare system. This is a polling, more recent polling about the anti-Muslim social climate. So Zogby did this poll in 2014, 45% of respondents nationally had unfavorable views of Muslims. Pew had this methodology where they would give you a thermometer. It's a really cool survey methodology. They give you a thermometer, hot, cold, rate these groups. And Muslims were the most negatively rated group, right, in the United States, across all other religious groups. The FBI reports that, this is a little bit dated, I don't know what the recent data is, but that there's been an 800% increase in hate crimes from pre-9/11, and this is still increasing. Well, that's society. What about the upper elites of our society who are in the media? I could put someone else's picture up here, but I didn't. So here, this is because this is about the medical care system. So anybody know who this individual is? This is Herman. Yeah, from a few years ago. He was also running for the esteemed office of the presidency of the United States. He talks about his surgeon. So he says, I discovered that one of my surgeons, he had cancer, was Dr. A.Padela. I said to his physician assistant, that sounds foreign. So, right, one way of discrimination is foreign medical graduate. She said, yeah, he's from Lebanon. Oh, Lebanon. My mind immediately started thinking, wait a minute, maybe his religious persuasion is different than mine. And she said, don't worry, Mr. Kane, he's a Christian from Lebanon. I said, hallelujah, thank God. So foreign, right, and then religion was his concern. And obviously he's a public personality and he raised this issue. In our own esteemed press, JAMA here, and this is from BMJ, we have this idea, and I'm just going to say this spillover. We have to be very careful, but that's spillover in the public sphere. Here's our own professional, highly rated periodicals. This book was reviewed, and how reviews occur in JAMA are that they're invited reviews. So this book was reviewed, Jihad in American Medicine, right? And the book largely portrays us to be wary of physicians of Middle Eastern descent because they might be fifth column within a hospital. And then we have to introduce more security checks about this. You have this idea about radical doctors. So there was a bombing, obviously, at the airport in Glasgow. So what does that mean for the NHS? So that's the implication. Oh, we have people who can bomb. What's going to happen in the NHS? What should we do? Right? At a pretty reputable journals. So that's the backdrop, that's the climate, that then you say we should study the American Muslim physician experience. And so that's what I set out to do. And there's a paper, you can look at that, but our research questions were, what's the prevalence of religious identity directed workplace discrimination? And are there any associations between physician characteristics and perceived discrimination? This study was done in 2013, so it's predating some of the more recent stuff that you've heard about. And there was no way, as I said, there's no way to get AMA master file Muslim physicians. So what we did was we partnered with the Islamic Medical Association North America, who allowed us to use their list server, their membership roster, to do a random survey of their membership. And luckily we were able to get foundation funding to do that work from the Template Foundation. So 3 waves, 746 physicians from this group we sampled. What we wanted to look at was, these are the measures specifically. So perceived religious discrimination at the workplace. We adapted this measure from all the other racial measures I told you, the other studies. And then we created a couple of items here talking about religious accommodation. These are the 2 items we created along a 5-point Likert scale. And then our predictor, the main thing that I was interested in was in religiosity's impact, right? So the thing was, well, there were a lot of people calling for having more religious presence and being tuned religiously in the healthcare environment, but can this identity ever be accommodated if it comes from this community in the healthcare workspace? Is it actually an exposure risk? So we had many different measures of religiosity. Okay. So here's the sample. We got 42% response rate. It should be over 50, I know. But we couldn't get that. We actually ran out of money trying to create incentives. The other studies on Muslim physicians have like 15% response rate. So this is the state of the art, the best anyone can get to for this population at present. And we had 250 almost. Most of the male, most South Asian. This is reflective of the population. Most immigrated as adult. Minority work at a teaching hospital, so a third. But they've been here a pretty long time, right? So these are not people who are just coming and are facing challenges now. So this was the population, and the religiosity profile, they're highly religious. So most important part of life, 54%. In terms of practice, you see that they pray sort of more than monthly, less than weekly, 51%. I mean, pray at the mosque. So it's not just prayer, right? So they're going to services. They're fasting Ramadan, all of Ramadan. And then this idea, you see nearly 50% would wear a hijab or have a beard. Right? So this is actually more religious than the American Muslim population at large, which is the opposite that you would find of physicians of other groups, right? So Farr Curlin, one of my mentors, he did survey religiosity profile of national of the U.S. population of physicians, and there were lower measures. So here, this is the opposite trend. All right, so here's our findings. In terms of discrimination outcomes, the frequency of religious discrimination over one's career, you had a quarter say sometimes or more frequently, and there was no predictor in our data set, religious profile or social demographic. That's what we adjusted for in all of these multivariate models. Currently 14%, right? And the only predictor was those individuals who felt religion was the most important part of their life, had a higher likelihood of facing current discrimination. If you move to workplace relations, greater scrutiny at work because of your religious identity, nearly 50% agree with that statement. And again, here, those who felt the religion was the most important part of their life, which is about greater than 50% of their sample, had a higher odds of having that association. We're getting to some good stuff here now. So religious identity positively influences relationships with colleagues. 66% agreed. And those who had a higher practice level of religiosity, prayer and frequency reading the Quran, would agree with this statement more likely, right? So this might be a protective effect. In terms of believe their religious identity is accommodated at work, look at that. Nearly 3/4 felt that way. And again, here, those with higher religiosity, in terms of importance, felt that way. So we'll have to explain this in a second. How did this happen, right? And struggling to pray at work, 50%. Here, again, those who have a sense that religion is the most part of their life, they had a lesser association here, lower odds, as those who don't work in academic environments, non-teaching hospital or solo office. Right? So those who are not in the academy, they struggle less with prayer, or report struggling less with prayer. Okay, so here's the summary, right? So the good, nearly 66% or greater felt that their religious identity was accommodated at work, and that Islam positively influenced collegial relationships. This is a good story. The problematic is that a quarter encountered religious discrimination sometimes or more often in their career. 14% in 2013 reported presently experienced discrimination, and nearly half struggled to pray at work. So here's the paradox, right? So the only predictor on our data set, right, you see there's very little about anything about when they emigrated to the United States, about their age, whether their sex, nothing, right? And we had power to do many of these analyses. I mean, so that's not the issue. So what is the issue? Well, the only predictor was individuals who feel religion is the most important part of their life, right? Which is more than half of the sample, had a higher odds of both perceiving discrimination at workplace, but also feeling that their identity was accommodated, and the lower odds of struggling to pray at work. So how do you resolve this tension? So there's some speculations I have to share with you. Obviously, a single snapshot study can't posit causality, and then we have limited understanding because we didn't interview individuals. But here are some ways to think about this. One, so if a Muslim physician's, it's importance, right? So their identity is informed by the religion first. Then whatever happens to them in their daily life, they might see it's because of that identity. So then any negative experiences are interpreted to be directed at that identity. It could be for some other reason, right? But they absorb it to be attracted by their religious identity. So it might be internal psychology of the individual who's facing these bad experiences. It could also be that physicians who have this religious identity, they're more attuned to conflicts between their faith and medical practice. So they're attuned to a conflict that leads to great exposure to discrimination, right? They draw attention to that matter. But at the same time, they might be more likely to, or more able to seek out accommodations. Okay, I can't do this, so I'm going to do that. So then they resolve that tension. They're proactive about the matter because religion is very important to them. One could also posit potentially a temporal association. So here, since working in non-academic environments is also associated with less struggle to pray, perhaps physicians choose to leave or are crowded out of certain types of workplaces. So they have the exposure and then they leave. They're crowded out, they're marginalized out, and they decide that I don't want to have that exposure again. So the rates of present discrimination are low, over career are somewhat high, and it's because of that religious identity. So they've worked it out by just being marginalized out of the profession. The implications for that are that we know from FAR's data that there's a protective nature of religiosity for physicians, right? Those who sense that their job is a calling, they have less burnout, they have less regret in choosing medicine, and they are less likely to leave their profession. So we have a recidivism issue if you feel that your religion is not sort of accommodated, because these people will then have these effects, the negative effects of this. And then we also know, we start off with the notion about social equity and diversity, right? So if groups of physicians, minorities or religious, face disincentives to work in academic hospitals or feel discriminated against, then all of that goes out the window, right? You won't have this notion of social equity, you're not righting the wrong, and all those benefits for patient care are not seen as well. So my great point, right, is that we should have diversity and inclusion agenda considering religious diversity and sensitivity training. Instead of traditionally, obviously, they focused on these issues, and we need to expand that scope. So that's my call for today. That's why I'm here. But as I discussed earlier this afternoon when talking about patients, the issues are always in the rub, right? So what aspects of religious identity are we going to accommodate? To what extent and how, right? And so as a bioethicist, that's why we need to be paid to do this sort of work, right? Because you can have all this wonderful data, but this is what we can help you with, but no one wants to pay our salaries. All right, anyway, so I'm going to do that. I'm going to share with you a few stories I've been involved with, actually, okay, so my career. And I want to see this is where we're going to then open up discussion, but I want to tell you this story about religious identity accommodation in the workplace. So the first story is medical school. So a medical student, she is doing her clerkships in the third year, and she's doing surgical clerkships, and she dons a hijab as this individual. These are not real pictures, although this is a person I know, and these people I know as well, but this is not the person involved, okay? So in any case, she is wearing a hijab, she goes into the OR, and the scrub nurse says you can't wear that in this hospital, you can't scrub in, you gotta go wear something else. There is nothing else for her to wear. She only brought that headscarf, so she doesn't go to surgery that day. A few days later, she goes back to surgical clerkship, and the person says, oh, you can wear a bouffant or whatever on top of that, and you can come into scrub in the OR. And then she says, okay, so now she thinks that's what's to do. So next time she goes in, and then the other scrub nurse throws her out. That's not policy. You have to do something else. So in her experience, every time she went to the OR, the person who was in charge was a scrub nurse, and that decided whether they can accommodate her or not. There was no policy. And then when she brought that up to the clerkship director, he said, you have to work it out with the hospital that you rotate at, because they control the show. These are sites that are agreeing for you to be a medical student training there. They run the show. It's not a university hospital that we own. Okay? So how do we accommodate that religious identity? And we'll talk about this. So that's case one. Case two is not Dr. Salmesi, but a resident, a Catholic resident who is in emergency medicine training. And part of emergency medicine residency training is that you should learn, one of the skill sets that you learn is ultrasound. And we do ultrasounds for pregnancy for people who come in with vaginal bleeding. So the way you learn that is you go to an abortion clinic, and you do ultrasounds before an abortion is performed, because then you know what it looks like when you have an early fetus, and when you can learn anatomy that way. So the resident says, I will not participate in this training opportunity, and decides, so the residency program says, well, this is part and parcel of becoming an emergency medicine physician. You need to learn the skill set. This is how we do it. We can't trust you to do it on patients unless you learn. So this goes back and forth. Ultimately, the physician decides not to get ultrasound certified for pregnancy evaluation, and decides that's not something that I'm going to have privileges over when I go to the hospitals. So I want to strike out that line as a scope of practice. So how do we accommodate that religious value when we're training people? You have a medical student who's applying for residency programs of Orthodox Jewish persuasion. He decides to email the program directors of the emergency medicine programs that he's looking at in a certain city. And he poses the question, I'm an Orthodox Jew, I have the Sabbath thing, I don't have that much money to spend on interviews. If you don't think you can accommodate me, let me know, that I won't apply. Can you accommodate me? So that's how he decided where he's going to apply for residency programs. And the chatter on the residency side, I'll tell you, so the resolution, but there's like, are we allowed to talk about what? I don't understand. Like, what he hasn't even applied. I don't even know if he's going to get an interview. Like, what is this? Like how do we deal with that? You have a medical school that is put in the Middle East. And the idea behind the medical school is that it's invited from the host country to create the same education experience that you have back in your country, in our country. So to have the same degrees, to have the same experience for our students. We want to create a medical school in the Gulf. So the class, they elect people come in, they have a medical school class. Part of the first year medical school class learning is that you learn prostate, breast, and vaginal examinations through paid actors. So people are given money, and 100 students learn the examinations this way. So that's what happens back home in the United States. So they said, well, we need to do this in your country, because you want the same education. The medical students revolt and say, we do not want, in the Middle East, we don't want this sort of education. We want to learn these exams differently. And the question is, well, you brought us here for a same degree, same education, same instructors. This is the way we teach doctors. This is our education. And so this is what you get. And that was our contract, that you weren't going to impinge upon our teaching experience. So that's how that is resolved. So how do we, the reason I share these stories is that this is real. It happens every day. But as I said, to show you that picture, we don't talk about it, and we don't have a rubric for thinking about it. But I think that accommodating religious identity in the healthcare workforce proceeds along a gradient, right? And you can talk about observances, like the idea of Shomer Shabbos residencies, that allow people to take off for Sabbath and they figure it out. You have this idea, the case I presented with hijab and prayer in the OR, right? There's 2 billion plus Muslims in the world. There are many operating theaters in Muslim countries. Do you think no one prays ever and breaks scrub and come back? I mean, do you think there's no surgery? There are ways to do it, but we have to expand our thinking. Or that no one wears a hijab in the OR. Then you can talk about beliefs and values, right? So this idea of the abortion and conscience clauses. How do we create structures in learning environments or in practice environments that we figure out alternate pathways for people to learn what they need to learn as trainees, right? Or to practice how they want to practice. Does everybody have to perform so? If you have an OBGYN sort of shop in a rural Montana, does that mean that you have to be performing elective abortions? Is that a job requirement? Is that what's put on the requirement? Or does it say you have to be board certified in OBGYN? Similar things here about withdrawal of life support. I put this on here because this happens in Tier 1 Michigan. We have issues around brain death in the Shia Muslim community and other communities as well. So how do we think about coming these beliefs and values? What if a physician does not want to participate in withdrawal life support? I'll tell you, as someone who's gone through medical training, that you can tell an ICU doctor, when the attending is a certain type of attending, you know that next week when you leave service, everybody will have withdrawn life support, or no one will have withdrawn life support. Right? That the biggest determinant, in my experience, of what happens is that physician's own framing of the matter to the family. And their own subjectivity and views of what they are comfortable with play a role. So own that. And lastly here, so this exam, I just told you about learning general exams on paid actors, right? So how do we accommodate religious motivations and worldviews for how they want to practice and learn medical care? Right? We have Catholic healthcare systems here. Obviously, we know the issues around contraceptive giving, right? But they have a mission and identity, and they decide this is how we're going to do things. It pervades their healthcare system. So we want to accommodate religious identity in the healthcare workforce. Well, where and how and what you're going to do? Because you're going to have to deal and think about these issues, which, to my understanding or my reading, we have not yet. We let things happen. So with that, I want to stop. I want to share you this story of how this ad came about, of my understanding of this story, and then we'll have time for discussion. So this is in Toronto. There were many hospitals in Greater Toronto, and there was one hospital that decided that this is no longer sanitary. It leads to higher infectious risk. So they didn't want nurses to wear hijabs or figure out what to do, and obviously they were more of a state-controlled healthcare system than ours. So a hospital down the street decided they're having all these issues about what to do with that. We don't care what's on your head. Just come work here. We need nurses to work in a hospital. So that was their actually a tactic to get a workforce. All right, well, that I'll stop. Thank you. I think there's going to be a mic that's rolling around for questions. I left plenty of time for questions, so if you don't have questions, we can all end early too. That's fine with me.
Using the microphone because this is being video. We want to hear your questions. And your questions to
So regarding workforce diversity, I was wondering, do you see it's more on the role of the staff to go and approach the higher levels of administration and try and encourage diversity, or is it more like the approach of the scholars and the researchers to go to them and present data? Because they're it's kind of like the top-down approach or the bottom-up approach.
Yeah.
And then to follow up, essentially, which way do you think would be more receptive, I guess?
I think that's a very important question of how do you motivate change in structures, right? And I don't think there ever is a top-down and only a grounds-up approach. There's always some sort of blend that people have champions for certain things, whether it be clinically driven or other ways, and then you have alignment with those values from top as well, right? So I used to be, and as an impressionable medical student, you might have the same view, but I'll give you a jaded view. I used to think that data creates action and change. I used to think that. I'm a little bit disappointed. Right? I also think people were rational actors, but that's also we can hope that data drives policy, but sometimes people's own views on things, whether or not supported by data, drive policy, or they might be a constituent, or they might be that we have to do something for some other reason. So that's what I mean. I think we have to kind of think about both ways. But I advocate, and as a researcher, I advocate the fact, look, we talk about all this stuff about diversity, but look, we're not seeing the negative effects of diversity, nor are we researching it. And when you try to apply for funding for it, no one wants to fund you. So what's the problem? Do we not really want to look at this issue? Or we talk about accommodation, but we don't want, right? So I, as you got from my talk earlier, I'm a philosophy guy, yeah? I'm a vision guy. Tell me what it is, and now I can decide I want to be there or not, but I can help you think about what you're doing, because you have to be all in. And oftentimes we have a lot of band-aid solutions and feel-good activities, but we're not all in. And that leads to people feeling in the healthcare workforce that they are just tokens and not included, right? You can be on the committee but never speak. You can say a lot of stuff and no one listens to you, right? So we can't do that. We can't do that anymore.
Can you speak to the pressures that Muslim healthcare providers are feeling in the current political climate here? Because it seems like the rhetoric has escalated incredibly, and many people are deeply concerned about this. And how do you think we can respond to that as individuals who to make a difference in a positive direction, but we're just not sure what to do.
Yeah, I think that's also a very important sort of practical question, and unfortunately, I don't have the greatest of answers for you. I think that here. That first of all, there is no data. Like we have some pockets of what people sort of say, that there's higher levels of discrimination. I also know that there's some studies done that people become motivated to become more civically engaged when they face discrimination, right? So they feel that I have to have more branch points in my life. People need to know me better. I don't want to be isolated. But then you have the opposite phenomenon. People say, I need to be isolated. I need to not engage, right? So you have these two different responses from within the community to challenges, right? Become insular. And you see that playing out in our political game as well. Become insular or become more connected. And who is dominant and who is not dominant and how that happens, I'm not actually sure how that happens. So I think as societies, or as individuals who perceive this notion, I mean, you're here because you're coming to this equity and diversity talk, I think that we have to recognize that feel good isn't enough. So that I invite you to my church and you have a space there is not enough. Am I standing with you, right, when you're being thrown garbage upon, right? You're on my committee and because I need a woman to be on my committee. But when I tell you that this is not going to work, am I going to do something about that? So I think that for me, and I come from, I own my skin, so I'm a Muslim physician, but I come from this idea that today's generation, right, is frustrated by lip service and feel-good activities. And I'm just saying that. I think that's shown to you by some of the phenomena in the political sphere, that it's not good enough. And what we need is culture change. And that culture change can occur from starting with feel-good activities, but something's going to come after that. Some bridge building has to occur, long durable relationships. So that's so I said I don't have a great answer for you, but that's my notion, that we need to be fully invested, both from inside the community and say, hey, we don't have a foot abroad, we have a foot here. We're here, both feet are here. And at the same time, the community needs to be receptive to those conversations. And there are going to be ones that are difficult to have. But we have to be, both in the healthcare system, I'm speaking more broadly, right? So when we open up our civic society for engagement, you're going to hear things that you don't want to hear. Are you prepared for that? You're going to invite them to speak about those things. And then can we resolve them? So that's where I think we need to go as a society to bring deep cultural change. I am as I said earlier, I think that the national experiment is what's happening in front of us, unfolding in front of us today, every day, in the primaries and whatever else it is. That's the national experiment. And that should scare some of us.
You can go first.
On the conflict between the Shia belief against not accepting brain death, how is that being resolved in places like Dearborn?
Yeah.
And without violating the idea that we don't treat cadavers, and the resources should not be used to treat cadavers.
Yeah.
How is that being resolved now?
So the one, so the question was about brain death. So I'll tell you that this is also that's kind of part of accommodating people's religious identity. And the solution in a hospital in Dearborn has been to sort of, the quote unquote, absolve the family of decision-making responsibility, to frame it as a medical decision of futility and not invite conversation about that. So
Some families pressed.
Well, I think we were pressed, but if you'd say there is nothing medically more to do, your loved one's we're going to withdraw life support in a couple of days, can we help you facilitate a meaningful passage from this life to next for you? That's a different conversation. Oh, well, you know what? We think he's brain dead. You may or may not understand what brain dead is. We don't know if you should do a second examination. What do you think about that? Right? I think so. That is a known. It's called absolving family of decision-making responsibilities, and they have people, chaplains or Muslim chaplains, and others who are interested parties who facilitate and liaise in these conversations. And they tell them, look, you can't sort of frame it in this way. You have to frame it that way, and you have to not engage them in this sort of way. Now, I'm not saying that's, first of all, it's not a fully Muslim phenomenon. There might be other issues. Secondarily, it's not all Muslims. It's Shia, and some Shia Muslims follow Ayatollah Sistani. So it's not something to be generalized. But my point is that we have an ability. This is right. So maybe the accommodation here is understanding we don't want to cause you moral distress in your religious identity. We don't want to make you culpable for sin. We don't want to. So we're going to accommodate that by creating a structure that looks this very sort of, paternalistic, but actually we're thinking about you when we do it.
Thanks, Azam. I appreciate your comments. It's a little depressing, though, actually, some of your data. And I'm wondering, you kind of left us without giving us a real sense of, you've admitted you're a vision guy, so I'm wondering what your vision is. Yeah. You referred to Catholic hospitals, but is your vision separate hospitals? Right. Is this a way of accommodation, or do you have other ideas about how to solve what seems like an intractable problem?
So I think there's two, right, so there's two sides. I think there's more than two sides, but at least two. Let's think about it from the sense of the healthcare system. So the formation of individuals, right? So we're talking about healthcare workforce diversity, and healthcare workforce diversity means that we want to create opportunities for individuals to become of service to society for the public health good, and how we form those individuals of the boundary positions between their own identity as religious individuals and that which they present in front of patients is something that needs to be talked about and discussed, right? In the United States, some of this is driven by law. We have conscious clauses, right? And, debate with Bush and pharmacies, whatever. But we have this idea that, look, there is a point at which you can decide to not participate in the delivery of healthcare, but our structure to resolve that is, do you have a duty to refer? Right? So you remove yourself, but you have a duty to refer. So we created a workaround for individuals by accommodating their value system within a pluralistic society, but not saying that, no, you have to, right? That you have to. So I think that I'm not promoting segregated hospitals in that sense or whatever else, but what I'm saying is that we have to take it on board and say, okay, we as a society and as a healthcare workforce, we're here in service of the patient. Therefore, when we have to explicate for ourselves when those boundary points are, and then create structures a priori to negotiate those when they exist. And now there might be places where they can't, right? So then the choice is if we're going to say that you have the choice, then the choice is for us to remove ourselves from those situations. So the fact that say here, right, Muslim physicians struggle to pray at work because they're in academic centers, right? Because they have demands from residents. I don't know what it was. They say, I want to go work in private practice because prayer is more important to me, that I pray on time. That's a choice they made, right? I think for society, that's a little problem because that means that we're marginalizing everybody else, but you can make negotiations at that individual level. So my vision for us as a society is that we decide or we think about at the point of formation of the professional identity, what boundary points we're willing to negotiate and what we're not. And then as a society, we create structures for that. So this is much easier said in a society where you have a state healthcare system, where you can have multiple layers of sort of services provided. Much harder here. But that's sort of one way. The second way, I think, in the patient side, all right, is from the patient perspective, I think that it should be, and this is going to sound weird, but let, in a sense, the market decide. So if a healthcare system is providing services to a population that they want, say it's a surgical suite that provides same gender concordance, whatever, and they're viable and they have a population that comes, let them have that center. Let them do their thing. They're serving a need that we can't serve. And that's good for us, right? That's good for us because if we can't create that structure ourselves for ethical issues or legal issues, then they can have the system. And you have that in certain places, right? Where you have public hospitals and have a certain sense of these are the services you provide. If you want some boutique stuff and service-wise, you got to go somewhere else, right? We could do that also for patient populations. So I think I think that having those multiple layers is something, because we deal with that in the United States, we'll have to create. But create with a vision and a strategy for where they're going to be and how they're going to be funded and what opportunities we give to patients to take care and what providers to take care. That's my thought in our environment here. As I shared earlier this afternoon, I think that part of the challenge to give prescriptions is that we don't have adequate data right, on where we want to, first of all, from patients, but also of what vision we would like to see. So we can't even talk about these issues, much less resolve them. Then why are you sitting up there giving a prescription how to do it, right? Because I could have a myth about what issues are, and then I would set the agenda and give you the wrong solution. I think also I'm somber because look at the lights. I mean, nice. Any other questions? Or you want to call it a day? All right then. Well, thank you for spending an hour or so with me.
I have one more question.
No.
Will you accept this gift?
Oh,
hey. No,
thank you.
no.
Thank you so much. Appreciate it.
Thank you.
Thank you. No, appreciate it.
Hey, can I get a picture of the two of you standing in the lectern? Because I realized I forgot to get photographs, so I don't want to leave without.
So you're studying conscience.